Yeah, thank you very much. It's a great honor for me to participate in your meeting. So let me introduce my presentation about far-out syndrome. Just maybe 3 years ago, I never heard about this syndrome, but when I find out what is it, I found a lot of senior patients who suffer from this problem. So far-out syndrome is a compression and entailment of the L5 nerve root in the extraforaminal area between the hypertrophied L5 transverse process and the sacral ala. At first, it was described by Wills in 1984, and he found that it's the degenerative deformities in elderly persons, or sometimes he found it on the young adults with the isthmic cholestasis, more than to second degree. So the syndrome is one of the manifestations of the lumbosacral transitional vertebra, which is seen in from 4 to 30% of the adult population. The lumbosacral transitional vertebra was classified into the 4 types. Type 1 is L5 transverse process hypertrophied. Type 2 to 4 are association with the pseudoarticular between the L5 transverse process and the sacral ala. Degenerative change leading to the facet arthrosis and extrafemoral compression of the L5 nerve root. So in a lot of cases, we finding the concomitant significant pathology. This is disc herniations, disc ossification, ligamentum flavum hypertrophy, facet hypertrophy, and some particular osteophytes, which have same clinics, and you should check this pathology too. The diagnostics of far-out syndrome, the main what we have to do, this is a CT scan. Sometimes we need MRI, and for the different diagnosis, we use the imaging. This is the case where you can see from on CT scan the foraminal stenosis and extraforaminal enhancement of the L5 nerve root with the hypertrophied transverse process of L5. And this is the MRI, where also hypertrophy and the mass effect, which entaped L5 nerve root on the old patient. So what are the treatment options, what we can suggest to our patients? So always we can start with NSAIDs. This is the golden standard of all treatment of all painful conditions on degenerative spine. Also, we can use physical therapy. We widely use epidural steroid blocks for the diagnostic reasons and also for the treatment reasons, and surgery. Foraminal nerve root steroid block is a very good treatment options for those patients. Under the X-ray control, we can make an injection, transforaminal injection through the L5 foramen, and remove the influence of L5 nerve root. If it's not useful, we can suggest to our patient the surgery. The first open decompression of the entablement of L5 nerve root was suggested by Wills on 1984. So he removed the pedicule lower half, transverse process entire, and part of the S1 body. And from another side, he put bone material for the good arthrodesis of the lower spine. But the main main result you can get the instability, because it was the time before transpedicular screw fixation. But now we're doing this remove the compression to L5 with the endoscopic UBE technique. The UBE technique is a very good option because the magnification and illumination, easy target pointing, panoramic view, less limitation walking space. So advantages is the 2 small incisions, low damage of muscles, no damage of spine ligaments, low bleeding, low infection rate, small scar formation, excellent view, short term of hospitalization, much cheaper than monoportal, and much less radiation for the patient and for the surgeon. So what we need for UBE? We need the all arthroscopic stuff, RF generator, 0-degree arthroscope, UB instrument sets, and that's just general instruments like a Kerrison, Ronger, and pituitary Rogers. For them, the compression of L5 root, we use dorsolateral or transforaminal approach. So this is the target points for this approach. We move 2 centimeters lateral from the external pedicular lateral pedicular line, and 2 centimeters between the 2 incisions. So that's like we draw on the patient the target points. So when we start, we should remove the we should find the joint and remove the alar distal TP joint from the nerve root. So what we have to do, we have to find the capsule of the joint surfaces, and with the chisels we should remove all the compression stuff to the L5 nerve root. So after the surgery, we should drain the wound. So our experience, we have more than 60 cases of far out syndrome. We already wrote the article about our experience on this field. So we get very good results. More than 80% have a good and excellent results and pain relief. So for conclusion, unilateral extraforaminal entapment of the L5 nerve root may be successfully decompressed by UBE. UBE approach may be considered as an alternative for endoscopic decompression for far out syndrome. Minimal soft tissue dissections, minimal blood loss, excellent magnification and visualization of pathology are advantages of this procedure. Thank you very much. If you have any questions, I would be pleased to answer it.
Thank you, Dr. Latif Vishchenko, for the wonderful presentation. If anyone has any questions, please put in the chat group. We will try to answer them at the end of the talks, and then or we can email you and contact you. Let's welcome our next speaker, Dr. Sidem Muncu from Sultan Belli State Hospital, Turkey. She's a member of Turkish Spine Society, AO Spine, and IHTSS. Her topic is UBE for beginners, some useful tips.
Yes. Hi, dear colleagues. My name is Dr. Çiğdem Mumcu. I am neurosurgeon in Turkey. I'm so happy to be part of this wonderful webinar. Today, I'm going to talk about UBE for beginners, some useful tips. To start with, I'll describe UBE, then I'll explain the base concept of this technique. After that, I'll talk about complications and how to prevent it. Then I'll present some cases and I'll finish my presentation. In the last 10 years, endoscopic surgery has had such a great progress. Recently, biportal endoscopic technique has been more popular. UBE is a new endoscopic technique for treatment of all degenerative spine disease. It is based on arthroscopic surgery. In this method, two portals are used. The one is for viewing and the other is for using instruments. And these two portals move independently, which is a big progress. Let's take a look at the UBE history. In 1996, Dr. Antoni from Argentina published the first article about translaminar lumbar epidural endoscopy, only for lumbar discectomy. Then in 2001, Dr. Abdul Ghaffar described it too. And 2003, Dr. Am from South Korea presented endoscopic lumbar discectomy using the UBE technique. Between 2003 and 2013, UBE surgeries extended from simple discectomy to treatment of stenosis and even fusion surgery. Let's move on to talk about the advantages of UBE. The merit of UBE is more familiar to spine surgeons. The endoscopic trajectory has same steps as conventional microsurgery with clear view. UBE provides a good visualization of contralateral, sublaminar, and foraminal areas. We can use all surgical instruments without any limitations. So UBE has a wide range of spectrum for indications. Moreover, UBE has many advantages such as protection of the musculoligamentous complex, a smaller incision, less postoperative back pain, and short hospitalization. Another advantage is that UBE does less postoperative morbidity by reducing incidence of epidural fibrosis. Furthermore, many complicated cases and also spine deformities can be treated with UBE. Let's watch these videos. The video on the left is UBE discectomy, and the one on the right is microscopic discectomy. You can see UBE view is much clearer, and it's also has more blood-free vision. That means clean view makes the surgery easier and safer. Here are the disadvantages. UBE is a great endoscopic procedure, but it is technically difficult. Especially neurosurgeons might not be familiar with arthroscopic equipment. So the surgeons need to be trained to specifically learn the manual skills. UBE surgery has a long learning curve. To the UBE surgery, you should have a 0 or 30-degree endoscope, RF device, shower system, irrigating system, and spatial UBE instruments. UBE has a wide range of indications, all kinds of degenerative spine disease, such as herniated disc, spinal stenosis, fusion surgery, revision surgery, facet cyst, and so on can be treated by UBE. For the moment, we cannot operate intradural pathologies and spinal infection by UBE. However, in the near future, we expect to achieve this. When you start UBE, we recommend you operate with easy discectomy cases at the level L5-S1, which has interlaminar window that is much wider, as it gives you much vulnerability. Later on, start with discectomy on the level of L4-5. By practicing more, then you can do with lateral recess decompression. And when you get more practice with using Biportal, you can start spinal canal stenosis. Then finally, you can perform with posterior foraminectomy in the cervical spine or far lateral discectomy. You will gain enough experience in your first 50 cases. And now I will talk about some tips of UBE surgery for beginners. First of all, operative preparing is very important. We should perform UBE under general anesthesia. It is better for both the patient and the surgeon. The patient must be in prone position with a neutral rolling bed. Also, 5 to 10 degree head up position is necessary to protect optimum ISP during the surgery. Wilson frame allows kyphotic posture, which would increase epidural pressure and lead to more epidural bleeding. We recommend you not to use it. The next issue is about your team. Your team is very important as well. There are lots of details to prepare before starting the UBE. That means your nurses need to know how to set up the water pump of the irrigation system, how to connect your video system, and so on. It's not only the surgeon who must be trained with the manual skills, but also your team, your nurses, your technical staff for the final success. The next issue I'd like to focus on is the technique. In here, you can see the operative steps. First one is skin marking, which is the basis for UBE. There are 2 portals. One is the working portal, the other is the scope portal. These 2 portals must create a triangle above the lamina, which is very crucial. Second step is to create a working space. For this, we clear upper lamina, interlaminar space, and lower lamina of soft tissue with the dilator. The next one is the irrigating system. It's essential to know how to use the irrigating system for fluid control, clear view, and bleeding control for patient safety. When you prepare the interlaminar space, the following step is similar to open microdiscectomy or microdecompression. This video shows us preparing the skin portal. For interlaminar approach, first we need to determine the midline. Then the second line should be drawn on the medial margin of upper pedicle. Third line should be in the disc level. These lines should form a triangle in the center of spinous process. Distance of 2 portals is about 2 to 3 centimeters. After the skin and fascia incisions, the 2 dilators are inserted through the lamina, and then the dilators met and create a triangle onto the upper lamina. Then muscle detachment is made by the dilator on the distal margin of the lamina and medial side of the facet joint before inserting an endoscope. It is necessary to prepare enough visual space. At the end, the scope and RF probe are inserted through the incisions. Then are created V-shaped working mode on the upper lamina. Finally, potential space is made with RF. So triangulation is crucial. If you make good triangulation, you can see the instrument in the screen. If you don't, that makes the surgery difficult. Irrigating system applies water flow continuously, so to control inflow and outflow is crucial. We should keep the pressure 30 and 50 millimeter mercury for patient safety. Controlled continuous outflow can make an optimal hydrostatic pressure. If outflow isn't proper, epidural pressure will increase and lead to some CNS complications. Good outflow gets clear view. Moreover, we can check the bleeding. If you lose anatomic orientation, the procedure becomes risky. We always need to know exactly where we are. We need to have full orientation. If you feel you are getting lost, you should convert to microsurgery. What is the complications? High hydrostatic pressure can cause CNS problems such as headache, posterior neck pain, seizure, blindness due to retinal bleeding, hydrocephalus, and pneumocephalus. RF ablation may cause thermal injury on muscles and cord as well. It does especially protein denaturation at between 40 to 70 Celsius. That is why RF device must be used for a short period. If you cause more muscular damage by RF, it can lead to muscle edema, then infection. If you want to get a good result, outflow should be continuous. At the same time, your surgical view should be clear. The scopic hand can be moved in all directions. If you go deeper and closer to the pathology, you can reach a clear vision. That is very important. To keep optimum ISP, first, patient should be in head-up position. Second, we always have to control the outflow. For this, the nurse holds the UBE retractor. Continuous output prevents complications. To prevent RF damage, you can relatively touch on dura of lumbar spine, but on cervical spine, don't. You should use RF for a short time and repeatedly. And also, you should avoid touching directly on dura of cord level. Let's talk about how we can control bleeding. Epidural vein usually bleeds. If there is bleeding, you should move the scope much deeper. Also, you can insert the suction tip here like a natural drain. Then fluid and blood will exit. Or you can coagulate directly with RF. If it doesn't work, you can use bone wax, gel foam, and so on. If you don't know where the focus of bleeding is, close the irrigation and wait for just 2 or 3 minutes. Clotting will happen spontaneously. Then you can restart. In this slide, you can see my UBE cases that I've performed for 2.5 years. In the beginning, I faced serious complications such as bilateral visual loss, epidural hematoma, and so on. I've learned how to avoid complications gradually, and now I will explain some vital details for beginners for a safe surgery. Now we will move on to look at some of my cases. This case was my first UBE case. He was 28 years old and had a right leg pain due to L5-S1 disc herniation. I performed UBE 2.5 years ago. There was no dural injury or any complication during the surgery. Post-operative, a few hours later, bilateral visual loss was observed. he was immediately referred to the Department of Ophthalmology. He had bilateral retinal hemorrhages. In this slide, you can see his fundus photograph of optic disc. He was applied YAG laser in both eyes. 1 month later, his visual acuity increased and the hemorrhages remarkably recovered. My second case is a 34-year-old woman. She had left leg pain for 3 months due to L4-5 disc herniation. Preoperative MRI shows the ruptured disc at L4-5. This is another section of her MRI. After the UBE surgery, right side surgery, ruptured disc was totally removed. There was no dural injury or any complication during the surgery. Post-operative MRI showed good decompression of the spinal canal, but she developed right foot drop after the surgery because of excessive L5 nerve retraction on the right side. She undertook physical therapy for a couple of months. Then she completely recovered 6 months later. Here you can see her intraoperative video. The surgeon should always be gentle with the dissection and handling of neural tissue in such cases. Third case is a 21-year-old man with severe left leg pain, which had lasted for 7 months. Operative MRI shows the ruptured disc at L4-5. After UBE discectomy, ruptured disc was totally removed. This intraoperative video shows us a ruptured disc compressed left L5 nerve root. At the end of the UBE, we can see discectomy is done and L5 root is decompressed well. Fourth case, 29-year-old man presented with severe pain in both legs with claudication. Preoperative MRI images show the severe spinal stenosis with herniated lumbar disc at L4-5 level. After UBE surgery, central canal is fully decompressed. Post-operative MRI was taken 1 day after the operation, showing the sufficient decompression of spinal canal and adequate resection of lumbar herniated disc. Here, this is the UBE stenosis surgery. Let's watch my last video about how to perform UBE. In this video, you can see that the surgical view is much clearer during the operation. conclusion, UBE technique gives a better visualization of all directions and detailed operative information. If we do operative preparing properly and make every operative steps right, UBE is an alternative and minimal invasive procedure for treatment of all degenerative spine disease. Thank you so much for your attention.
Thank you, Dr. Sidam Munchu, for this wonderful, insightful presentation, certainly useful for beginners of UBE. Any questions, please record it and ask at the chat box or at the end of the sessions. Now let's welcome Dr. Tan Rong from PLA Strategic Support Force Characteristic Medical Center, China. He's the member of various spine associations in China. He's going to share his precious experience in preliminary experience of lumbar spine fusion by UBE. Welcome.
I'm Dr. Tan from Beijing, China. Thanks very much for the invitation from chairman of this webinar. Today, I'd like to share some preliminary experience of UBE leaf. As we know, unilateral biportal endoscopy, it seems like a transfer from the arthroscopy from the knee joint, hip joint to the spine. Nowadays, uniportal endoscopy developed rapidly to address various soft disc herniations, but it has a steep learning curve, and it's very difficult to remove some nucleus in some special cases. And the decompression efficiency of spine stenosis is not very high. And full endoscopic lumbar interbody fusion is still being explored. So I think the uniportal endoscopy can deal well with protrusion of the disc, but to deal with stenosis, lumbar spondylolisthesis, like a fusion, maybe it is not very easy. So compared to uniportal endoscopy, UBE has many advantages. For example, combine the advantages of endoscopy and open surgery technique. The observation and the operation channels are separate, so you can use the regular instruments, use the conventional equipment with high efficiency. It has wide opening range and a wide field of vision. It was born for narrowing, spinal canal narrow. So I think can it be used for lumbar spine fusion? Before I perform this technique, I like to check some literature. And nowadays, we have many kinds of techniques to do the lumbar interbody fusion, like A-leaf, O-leaf, X-leaf, and a P-leaf, T-leaf. There are some difference between these techniques. Most of the difference is approach and the number of portal and what kind of cage they use. For UBE leaf is a new technique. I performed this technique 1 year and a half years ago. A literature shows different techniques. The first is uniportal. The medium is water. The second is biportal. Also, the medium is water. The second is like mixed leaf with tuber. This literature also shows the views of different kind of technique for full endoscopic leaf and ULIF and misTLIF, we can clearly see that the ULIF is much more clear than the misTLIF. Maybe the same like F4 endoscopy if people reported some results of the ULIF. There were 69 cases and average 71 years, follow-up about 14 months. And the average blood loss was less than 100 milliliter. So the mean operation is about 2 hours and a half. A complication is about 70%. But the fusion rate was not reported. These are the pictures shows how to do the ULIF. And also give a conclusion that UB provides direct decompression. And the result is similar to open lumbar fusion. And it is a new option for minimally invasive lumbar fusion. Another literature shows that 14 cases, and it is almost the same result. These are the pictures show how to choose the incisions. For TLIF, use the like icons with red color. I usually use the outer line of the pedicle. And the conclusion is that ULIF is a new surgical option for lumbar spine, which can enlarge the surgical field and fully decompress and directly see the preparation of the end plate. So how about ULIF compares to PLIF? This literature shows 70 cases ULIF and 70 cases of PLIF. The average age was 68 years old. The patient we followed about 1 year and a half. The mean operating time was like 2 hours and a half. The fusion rate is a little bit different. For the ULIF group is 74%. For the PLIF group is 92%. And the complications are similar. So the conclusion is that ULIF is a less invasive technique, while just as effective as conventional PLIF, improving clinical outcomes and obtain fusion. However, ULIF has a longer operation time than PLIF and requires further development to improve the fusion rate. These are the cases that I did 1 year ago. This is a 60 years old female. She had the recurrent low back pain for 4 years and intermittent claudication for 2 years. And from the X-ray, we can show the spondylolysis of L4. The MRI shows the spinal stenosis at L5 level. And the CT scan shows the severe hyperplasia and osteoarthritis of the lumbar 4-5 facet joint. Incision plane, I prefer the outer line of the pedicle. These are the pictures taken during the operation, and it shows the resection of the facet, decompression of the node root, and to deal with the end plate with bone graft. I use kits that I routinely use for the open surgery. After protect the node root with a tractor, I can use the routine kit. And the bone graft is allograft. The bone is from the facet joint and the lamina. And for the ipsilateral, I use the same incision for UB. These are the pedicle screws, the percutaneous pedicle screws. These are the pictures after insertion. So the post-operative X-ray shows the reduction of the L4 and in the body fusion bone graft. And the CT scan shows alignment and bone graft is very sufficient. The patient did very well, and low back pain almost disappeared, and the low limb symptoms disappeared immediately after the operation. Case 2, a female of 46 years old, and she had caudal equina syndrome. There are normal at the X-ray in the X-ray. For MRI, we can see that a large disc herniation at lumbar 5 S1, and we can see the severe compression of caudal equina. The localization before I did this operation, I prefer use a needle inserted from the contralateral side, and the needle direction is directed to the intervertebral space. Then when I do the operation, well, I will not easy to lose the direction. These are the pictures both for bone grafting and trial and inserted the cage, and also the incisions and after the percutaneous pedicle fixation. These are the videos during the operation, shows to make the cave and decompression and remove the disc and insert the cage. These are pictures for after post-operation. This patient did very well after the operation. Low back pain was scored 2, and the caudal equina symptoms partially relieved immediately after the operation, and she recovered 3 months after the operation. The third case is a 60 years female, and she had intermittent low back pain for 6 years, aggravated for 3 months. From the MRI, we can see a little bit spondylolisthesis, and the disc height is a little bit lower for L4-5 level. And the CT scan shows a little bit arthrosis is the L4-5 facet joint. I did the discography to judge the source of pain. We did L3-4-5-5S1, and the results suggested that the pain is from L4-5. This is the picture that shows before I do the operation, I will use 3 needles to localization the working portal, the scopy, and the needle on the contralateral side is directed to the disc space. Then when I do the operation, can keep the orientation. These are the pictures took during the operation. the incisions and the anteplate preparation and the insertion of the cage, also the percutaneous pedicle screw fixation. These are also the videos during decompression and no root and insertion of the cage. Post-operative shows that the alignment is good and the instrument is in well position. The CT scan shows that maybe the bone graft at the L4-5 is not enough, but the patient did very well, and low back pain gone after the operation, and this patient is about 1 year after 1 year follow-up. She did very well without loosening of the pedicle screws or the rods. These are the videos. She did very well. So preliminary experience for people who want to do the lumbar fusion with UBE. It's a new option for microscopic fusion. It has double channel, large operation channel, and with high efficiency. With water medium, and the vision is very clear. It can do sufficient decompression and also bilateral decompression. The cage insertion is under the monitor of endoscope, so it is much safer than the Unilateral. It is similar to the posterior approach for the surgeons, and it is like arthroscopy and plus routine spinal instrumentation. But if you want to do UBE very well, maybe you need some special instruments. It is not as easy as you think. We must do careful preoperative planning for different side, for different level. The experience is not the same. So we should from like L5 S1, and then we can to do the fusion step by step. The channel is separated, so we need a time to adapt for left hand and right hand to adapt. At the first several cases, maybe it is easy to lose orientation. So be careful. We don't know the wrong level. So the initial cavity building is very hard, but with more practice, the time will be shorter quickly. So it's a single hand operation. So sometimes it is not very convenient. For summary, UBE is a new option for minimally invasive lumbar fusion. It is technically difficult at the very beginning. So we should be carefully select the case from easy to difficult. And we should do plenty preoperative preparation and design. It is very important we keep the orientation during the operation. And if you want to do the operation more safety, you can use the electrophysiological monitoring. And also, every case, when you start using this technique, you always have a B plan, like a microscopic or mistilif. So the efficiency will be improvement. Then what I worried about is long-term fusion rate maybe we should use more bone graft and practice. I think it is a very good technique for you. Anyway, safety is the first. Thank you very much.
Thank you, Dr. Tan Rong, for the very good presentation. Now let's invite Dr. Cheng Ing from Comet Hospital, Cambodia. Dr. Cheng Ing gets the Certificate of Endoscopic Spine Surgery Technique, UBE, at Park Woon Wong Hospital in Busan, South Korea. He's the teacher of neuroanatomy and Bachelor of Medical Sciences, University of Health Science. His topic is first UBE experience in Cambodia. Welcome.
Dear colleagues, I am Dr. Cheng Ing from Cambodia. Thanks for my speech here. It is my great honor to present my presentation about the first UBE at Calumet Hospital in Cambodia. This is my hospital. Cambodia, I present about my country. My country in South Asia. It is 181,000 square kilometer. 3 countries around Cambodia, like Thailand, Laos, and Vietnam. This is Angkor Wat Temple. Phnom Penh, only one capital. Economic industry. Population around 2 million. In Phnom Penh, we have 4 reference hospitals. Calumet Hospital. We have 132 doctor specialists, professor assistant 2, 16 professor, and 900 beds for the patient. I talk a little bit about my background. 2001-2007, I am a medical student. 2007-2011, I am a resident general surgery in Phnom Penh. 2012 to 2013, fellowship neurosurgery in France. After that, I work at Calumet Hospital in Cambodia as neurosurgeon. This is my photo in France, 2012. Why Cambodia need UBE? Because open surgery, you not so clear. Big incision, too much decision, muscle and bone, and too much pain post-operation. Benefit for UBE, safe, minimal, invasive, and endoscopic is the next step for Cambodia patient. And also around my country like Thailand and Vietnam, we already have endoscopic spine surgery. UBE is adaptive technique for us. Right now we have arthroscopy and conventional material. And UBE is less radiography in OR than other techniques. How to make it happen? I start my field in neurosurgeon in 2013. Every reference hospital do open surgery in spine degenerative. In 2019, at the first time I can contact with Dr. Sun by brother Casey in South Korea, that to have the first step in UBE surgery for me. In my mind, 7 days in South Korea, it is enough to learn. It is easy to understand with me neurosurgeon without knowledge with endoscopic spine surgery. It is easy to medical doctor graduate fellowship in France and understand English language. But finally, I had to go. In September 2019, I went to Park Woon Wong Hospital. Over there, I get a warm welcome by Master Sun, Brother Casey, and also I meet my friend over there, Chinese, Ukraine, and Mexico. at 7 days in South Korea. And we have 2 or 3 cases done per day, like lumbar disc hernia, OLF, lumbar spine stenosis. A big problem with English language, but I have a good facility arranged by Brother Casey. The big dream I never thought about UBE can do ULIF. UBE can do in spine stenosis. How to bring UBE to Cambodia? 3 months later, after I came back, Brother Casey come to Cambodia with complete set, camera system, radio frequency, and server. Day by day, we start to perform by myself to adapt with camera system. After that, we do simulation with a pig in OR. The first case I do, it's the first case, male, 27 years old. She complained lumbar back pain with right leg weakness for several months. In my OR, we have C-arm and colon for UBE. The patient with the special drug from South Korea. Yeah, I saw a little bit my video in my first case. We done on 9 December 2020. What I meet in my first case in the real operation. 1. With irrigation system. Sometimes we have to push to make you clear. We need a lot of water. Not directly to lamina, and at the end, a limitation to move Cartesian punch. My second case, recurrent lumbar disc hernia, L4-5, male, 50 years old, medical history. He used to do endoscopy spine surgery, lumbar disc hernia, L4-5, 5 years ago in Thailand. She complained lumbar back pain with left leg weakness for several months. This is my second case. My third case. Female, 28 years old. She complained lumbar back pain and both leg weakness for 7 months. MRI showed L4-5 lumbar disc hernia. After 3 cases, UBE give a better line and short than open surgery, less pain and aesthetic. UBE is not for only lumbar disc hernia. It is just a beginner for me, but it is this for the spine degenerative disease. Following the standard procedure of UBE, the outcome is unique. Future plan for UBE in Cambodia. We have plan to have association UBE in Cambodia. And we also plan to have simulation for UBE technique at University of Health Science in Phnom Penh. Already support from Dr. Sun and faculty. We bring UBE to the public. We try to make my people to know we can perform endoscopic spine surgery in Cambodia. At the end of my presentation, my thought in UBE. UBE is not only for the business, but it is also the happiness and for the patient and also for their family. Thanks for your attention. Thank you.